to think about when it comes to the things that you do are, do these symptoms cause distress, not only for the person that is experiencing them, but also thinking about the people around them. How frequent and time-consuming are the symptoms? So is it more than an hour per day is just one thing to think of. For some of our patients, they may be ritualizing 8, 10, 12 hours a day. I mean, it takes up a serious amount of time. Obviously, the ones who aren't as severe, it's going to take up less time, but thinking about it as at least an hour per day. And how much interference with normal activity. So is it causing dysfunction? Are people able to pay attention at school, get ready in the morning? Are they able to socialize and go out with friends, or is it disrupting their family? So those are pretty significant questions that we need to think about to decide if it's really OCD. One of the assessments we use, I put SIBOX in adults, it's the Y-box, so the Children's Yale-Brown Obsessive Compulsive Scale is something we use in our patients with OCD here. We use it not only as part of our assessment to see how severe they are, but also we use it as tracking their progress during treatment. So we do it about every 2 weeks in our OCD programs. It's a pretty simple scale to use. It's a self-report scale both in children and adults. There are 10 questions on it about obsessions and compulsions, and then we look at it to see sort of how severe they are and if they're making that progress. Again, in the adults, drop off this, it's just a Y box. There's also a symptom checklist that goes with the SIBOX and Y box that is very extensive, but it's not something you score. It just gives us information. Thinking about what causes OCD. OCD we know a lot about, but I still think there's more to know about as well. We do believe it's a neurobiological illness, just like we do with other mental health diagnoses, caused by an imbalance of certain brain chemicals. We know that serotonin is at least a major player. We believe that glutamate is as well. So there's some new research going on about the role of glutamate, but I think we're understanding more and more about the brain pathway. We definitely know it has a genetic component. For every kid that we get here with OCD, we know that 20% of their parents will have a diagnosis of OCD as well. It can be preceded by a strep infection. I'm not here to do a lecture about PANDAS, but it is something that we do see here. PANDAS is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. And in those kids, within 72 hours of a strep infection, they may develop tics and or OCD. Typically, the majority of kids can be treated with an antibiotic and it resolves, although for some kids it really throws off their immunologic system and they become pretty ill when it comes to their OCD and tics. So we get those kids here. So you will see some people with a diagnosis of PANDAS. And then also, we also know that OCD can be maintained by negative reinforcement, thinking about things like family accommodation that I'll talk about, where reinforcing behaviors that are not beneficial for the patient continue to go on. OCD is not poor parenting. They are very difficult kids to parent. We do believe that parents make, mistakes in parenting, just like every parent makes a mistake. But it's because OCD really takes advantage of typical parenting strategies. Most kids you can reassure and they're fine. These kids you reassure them and you're like setting off an atomic bomb. So we'll talk about that. It's not a sign of misbehavior and it's also not a lack of self-control. So again, a neurobiological illness. We also know that stressful life events can potentially trigger someone who's already predisposed to having OCD. So perhaps someone has a genetic risk or is showing some OC symptoms, but then they have a really stressful event and it kind of sets off a chain of events. So it can be something like a death of a loved one, the birth of a sibling. We see that very frequently on Child Center where the birth of a sibling has really set things off. A divorce in parents, a new school year, a move to a new house is a big one too. That kind of change can be really difficult, or an illness. Stress can absolutely worsen symptoms of OCD, just like it can depression or other mental health issues. We can see OCD as early as 3. We've actually had some parents tell us that they believe OCD started in the womb, that they think their child was flipping around like in sets of numbers, like in 3s and stuff. So I don't know how true that is, but we do know it can start very young. Many kids, when they're 2, line up toys. So if you go home tonight and your toddler lines up some toys, that doesn't mean that they have OCD. That is a very normal part of development, but if it continues to go on and cause dysfunction. If you actually look at the studies, most people are not diagnosed until they're an adult. But if you look at their symptom reports, they'll say it often started around age 10. It's part of the reason that we have the residential programs for the younger kids for this, because we want to catch it early, because we know the longer it goes on in a severe form, it can cause more and more dysfunction and disability in a person. And as I mentioned before, about 20% of children with OCD have a family member with OCD. So family involvement is often something that we think about here. It's really important that we educate our families. And I can't give you all the parenting strategies for a kid with OCD, but I just want to talk about a couple of really specific things. Because when we talk with the families of these kiddos, we really have to work on certain things. So we want to help them so they're not having the child avoid things or also participate in their rituals. So there's a really important concept in OCD called family accommodation. And if there's family accommodation, which occurs in about 90% of families, I would say it occurs in 100% of families to some degree, but in 90% it reinforces the OCD. So something like a parent may, if a child is hand washing, they may go get them a very clean towel, or what would be considered a clean towel from the child from another room and bring it to them so they can dry off their hands because they can't be contaminated. Kids who wash their hands 100 times a day, you can imagine they're going through a tremendous amount of soap. Probably the 8-year-old's not going to the store to buy that much soap. So parents buying items as part of rituals, parents participating in rituals, parents accommodating the avoidance is a really important concept that we have to reinforce with families. They do it because they think they are helping. They are not doing it on purpose to be bad parents. They really believe they're doing the right thing, and we have to help them see that you can't participate in the rituals, because we know that it maintains OCD. And it also says to the child that I do have something to be fearful of. So family accommodation is associated with poorer treatment outcome in children and adults. It's linked to high family dysfunction and stress because, frankly, if you're always going to the store or you're always doing laundry to maintain things to keep the child from being contaminated, you're probably pretty tired, and you're probably not paying attention to your other children. And then they get stressed. So reducing family accommodation is a really important part of treatment. And how they might be involved are some things I've mentioned. Requests for reassurance are incredibly frequent. I don't think I know an OCD kid who doesn't ask for reassurance. So they'll ask their parents, is the door locked? Are my hands clean? Will Daddy be okay when he drives to work this morning? And again, in a normal child, you say, oh yeah, that's fine, and they move on. These kids do not. They like to confess to parents about that they had a bad thought or that they pushed somebody maybe related to their OCD. They ask you to repeat things, so they may script you is what we call it. So they'll have you repeat things over and over again to them. They may have the parent check. And again, this is accommodating if the parent is going in the closet to check for the monster or the burglar or whatever they're afraid of, or checking the light switches and door locks. And then again, families are really involved typically in avoidance. So in the beginning they think, oh, it's okay if they stay home from school today or they don't go to music recital or to their sports event, but then it starts to snowball. So they'll allow them to avoid a variety of things. Again, not ill-intended, all thinking that they're doing the right thing, and then all of a sudden they're trapped in like this world of OCD. So we'll talk about how to reduce that as staff ourselves to that reassurance and that accommodation. So thinking about the basic ways that OCD is treated, exposure and response prevention is the most effective thing that we can offer someone with OCD. A lot of people know it as exposure and ritual prevention, same thing. But whatever that response is to the anxiety, that's what we want to prevent. It's considered the gold standard for treatment, whether it's outpatient, inpatient, residential, it doesn't matter. It's got to be part of the treatment. So exposure is a process where we systematically and gradually confront the thing that we're scared of, whether it's an object, a situation, or a person that produces that anxiety. And then response prevention is truly not doing whatever ritual it is. So it requires that person from engaging in a compulsion to reduce their anxiety or distress. And I'll give you an example here in a minute. So this is actually OCD. This is not exposure response prevention. So right down here you have time. It's over 60 seconds. That's just a number chosen. Here's the anxiety level. And typically, let's say if I was concerned about contamination and I touched a doorknob that I thought was contaminated. So I touch it and my anxiety shoots up. So now I'm really, really anxious because I think I'm contaminated. And so now I ritualize. I go wash my hands. And so here my anxiety drops very quickly and I feel better. So it works, right? The ritual works for a short period of time. But think again, if I touch the doorknob again, I'm going to go up. I got to do my ritual to come down. So it's just this repeating triangle over and over. And sometimes I still get higher anxiety. It doesn't necessarily just stay at that level. But with ERP, we're confronting the same thing. So let's say I think that this table is super contaminated. So what I would ask someone to do who's scared of contamination is we're going to expose them to the thing they're scared of. So I want you to touch this table that I think is really contaminated, and your anxiety is going to go up. That seems weird, right? I just made somebody super anxious. But what happens is the longer I sit here and the more I let my hand touch, just with the passage of time, my anxiety is going to go down. I'm not going to keep the same level of anxiety. Most people can do this for 1 minute, 2 minutes, and their anxiety is almost completely gone or cut in half. Occasionally, we've had people who've had to do it for extended periods of time, obviously maybe not just this thing, but whatever their exposure is, before their anxiety comes down. But it's pretty simple. I face my anxiety, I don't hand wash, and over time, my anxiety comes down, and that's called habituation. I'm actually going to move this over here. So, the joys of facing your anxiety, you get to do it over and over and over and over again. So, I come back the second time. I touch this. I survived the first time. I didn't get sick. I do it again. My anxiety doesn't go as high this time. And with the passage of time, my anxiety cuts in half. So we typically here at Rogers, I'll show you one of our pages, we do 5 trials, and you can see we get something called in-trial habituation, which means in the trial, my anxiety comes down. But we also get between trial habituation, so the preceding trials get easier and easier to do. So the more and more I face my anxiety, the easier it gets. So it is very clear in anxiety research, you got to face it and go through it. You can't go around it. So this is what a typical ERP trial looks like at Rogers. So we kind of have our own, sheets and things here that we do that have been developed by Dr. Riemann over a long period of time. And so you'll record your 5 trials. So let's say it's to touch this table that's really contaminated 5 times. And you're going to record how high your anxiety got. Here at Rogers, we use a 0 to 7 scale. 7 is basically panic level. 0 is obviously none. And then you're going to write down how long it took for your anxiety to cut in half. So this is pretty representative. I mean, most of even our little kids, their anxiety comes down within minutes. And so you see the time even gets less and less for it to cut in half. So we're seeing in-trial habituation, and now between trial habituation. Any questions about that?
So are you asking people to rate that, or the staff is rating it?
No, the patient is rating this. Now the staff are watching it because if I'm like, that's not really doing the exposure. So staff are watching to make sure that if the expectation, now we write very specific exposures. We may say, put 2 fingers to medium contaminated table. So they're going to do this. But if we write hand touching medium table, we expect them to do this. That's where we want staff to watch and read exactly what the exposure is, because this doesn't count. And so then even our 8-year-olds on Child Center can record these things. Now, obviously, we want you guys watching to make sure that they're recording and that they're not making up things because, kids will be kids, so sometimes they make up stuff. But they're rating their anxiety. both peak and final, and then you see them, all the OCD patients have little timers because they're all recording how much time it takes for their anxiety to cut in half with exposure trials.
Is it the 7 on 7 scale?
Yeah, the 0 to 7. And I think I have, yeah. So when we're doing hierarchy development, we use the 0 to 7 scale. I didn't bring it with me, but I'm sure it's on the P drive. Our 0 to 7 scale that we have, it actually describes each level of anxiety. And what we consider, when we're building a hierarchy, we don't care about the 1s and 2s. They don't really matter. They're not a problem. You can face them. We all have a little bit of anxiety at different times. And so that's not interfering. When we get to 3s to 7s, that's what we're working on. So we start at 3. We consider it to be challenging but manageable. So, maybe for me, this is a 3, but maybe touching that door is a 5 because all of you guys touched it. Probably all of you guys didn't touch that corner of the table. So we'll break it down in those ways. So what's high traffic, medium traffic when it comes to contamination. So it's really specific. We consider it to be a roadmap for treatment. And you'll see with our hierarchies, they'll have the number above it. So they may have a 3 written at the top of the paper, and then they'll have a whole list of all the exposures that our behavioral specialists have helped develop related to that person's OCD. And then there'll be a page of 4s and a page of 5s and a page of 6s, sometimes 2 or 3 pages of numbers. And there can be hundreds of items. We've had kids, 200s, in the 200s easily for how many things. Now, the really nice thing, because not only do we get the in-trial habituation and the between-trial habituation, but now they start getting confident, right? Oh my gosh, I can face my anxiety. I can make it through. So now, when they first came to treatment, they rated something as a 7. So maybe me touching the bottom of my shoe is a 7. Not for me, really, but for them it might be. But now when they actually go to do it, because they've done their 3s and 4s and 5s, they get to do it, and they're like, it's actually easier than I thought it would be. So they actually gain momentum, and things become less anxious over time. And our goal is for them to complete in any level of care that we